And it is actually my pleasure to introduce Dr. Discern, Dr. Santini, Dr. Komrocki. I actually consider them like my family, actually. We've been together for, what, God knows, more than 20 years working together? Yeah, okay. And, but the reason I'm in the podium is not only to introduce them, is some of you don't have access in the app to the question and answer. And in your tables, you have those little cartulinas, as we say in Spanish, where you can write your question, and maybe you don't have access to that, like ask us. Anyways, Amy.
All right. It's always wonderful to have an introduction from a big brother, so thank you very much for that. So we've had a nice introduction to anemia and some of the biology and the really excellent speakers that came prior. And so I'll start with a very realistic case from my clinic. As many of you know, the median age of MDS is usually in the early 70s at presentation, and this gentleman, because there's also a male predominance, presented with fatigue, well articulated by Dr. Mascarenhas' patient, how much patients suffer with this, with severe anemia of a hemoglobin of 7.8 grams per deciliter. His white count and platelets were within normal limits at the time of presentation. He then underwent a diagnostic workup with a marrow biopsy that confirmed the diagnosis of MDS with multilineage dysplasia, a low blast count of only 1%, ring sideroblast of 8%, and a normal male karyotype. 40 gene panel revealed a DNMT3A mutation and AXL1 mutations. His erythropoietin level was 260. He's currently red cell transfusion dependent with 1 unit every 2 weeks. All right, so as Dr. Garcia-Manero mentioned, you may write your answers on the cards on your table, or please use the polling tool to tell us which therapy you would recommend for this patient to start with. An ESA, Luspatercept, lenalidomide, imetelstat, and azacitidine. So 50-50, maybe. I actually think a case probably could be made for each and every one of these, and it does show that there's not all uniformity in our therapeutic thoughts, and there were a number of key features of that case that might have pushed someone down one way or another. The multilineage dysplasia, the ASXL1, the low baseline EPO level, the transfusion dependence, fairly heavy at the time of diagnosis, so all reasons to think these were therapies that could be considered. We'll go through a little bit of data throughout the course of this. So in this particular case, following the COMMAND study, which you'll hear about from one of my colleagues, the patient was started on Luspatercept at the first dose of 1 milligram per kilogram, subcutaneous every 3 weeks. And after a couple doses, he was still fatigued, but his hemoglobin had not changed much. He still needed transfusions, but less frequently than every 2 weeks, down to once a month. So what would you recommend at this point? You could increase the Luspatercept dose. You could switch back to an ESA. You could move on to a imetelstat. You could use one of the hypomethylating agents, or you could try lenalidomide. Well, I think we have much more uniformity here. So it seems like once we made the first choice, people want to use it to its maximal ability before we call it a wash, which I think is very fair. And we had emphasized that he only started at 1 milligram per kilogram, so certainly could go to 1.33 and even on to 1.75, and it is important to continue to push the dose in that regard. So, as all of you know, and I think this case illustrates, while an anemia predominant presentation of a male in his 70s with technically lower risk MDS, the pathogenesis is very complex, and I think the initial therapy choices that varied in the room tell us that there's lots of things that we try and help for these patients with our therapies. And it's because the pathogenesis is so complex. We know that epigenetic alterations are at the heart of it. Maybe this is the reason some of you chose to use HMA. You know, it's a true bone marrow failure disorder. That's probably why many of you chose an erythropoiesis-stimulating agent or even Luspatercept, as we've heard a little bit about, as a late-stage maturation agent. You know, in the early stages, we have the ability to guide our therapies with some of the dysplasia, the maturation, or the depth of cytopenias. Later on, closer to leukemia, we have different goals, but today we're focusing on anemia predominance and mostly lower risk disease. Certainly making the diagnosis of MDS should not be taken for granted. There are minimal diagnostic criteria which can be important, and the persistent cytopenia is different for men and women. You heard a little bit about this from Matteo, and the ANC and the platelets are shown there. Excluding other causes is increasingly important in the world where people have more vitamin deficiencies on some of our weight loss drugs, other infections, alcohol abuse, and so forth that I suspect this group knows quite well. We still greatly value morphology, and we'll hear from one of our pathology friends later on, but dysplasia still matters. And I think you heard the multilineage dysplasia in that prompt, and that may have pushed some of you down a different therapy or another. Increased blasts is obviously a sign of higher risk disease, and those may not be the anemia predominant, normal platelets, normal white count like this gentleman was. And certainly there are MDS defining karyotypes, and the major criteria have to be met with the prerequisite criteria to diagnose MDS. And so all of the discussions we have today are predicated on the diagnosis being correct. SF3B1 is one of the most commonly mutated genes, especially in anemia predominant lower risk MDS. You heard this from Matteo as well. And certainly the frequency of different genes among the MDS spectrums goes along with what you see in the histogram plot here. But SF3B1 in particular is mutated in more than 80% of patients with the ring sideroblast, and is thought to be a founder mutation. And this person, you may recall, only had about 8% ring sideroblasts, and some people use that number quite haphazardly. Some people are very rigorous, depending on where your pathology is read. But the mutation, I believe, is quite important if the ring sideroblasts are not in excess of 15%. The WHO MDS classification in 2022 did leave us with some different flavors of diagnostics for low blasts and an isolated 5Q. We know this is important for something like lenalidomide. SF3B1 is also a genetically defined entity now, and this gets back to why that mutation is so important with or without ring sideroblasts. And the third genetic definition was biallelic TP53, which we're not talking about today, and certainly those patients are low-hanging fruit for other initiatives. In terms of morphology, low blasts, hypoplastic, increased blasts, or fibrosis are all important in the WHO as well, and it may be in the relative near term this gets revised again, which may be helpful for our diagnosis. So you heard a lot earlier about what an impact anemia makes on the MDS patient's life, and our therapeutic goals are really couched on how our patients are doing. Certainly if they're transfusion independent, it's been alluded to that perhaps earlier intervention may have merit still, and we'll hear more about this in a little bit, but an appropriate monitoring plan at a minimum is absolutely critical for these patients. And then in the case of this gentleman, decreasing his transfusion burden is really important. For one, all the time we all voted that these patients spend in the transfusion chair, but also the Red Cross stores are at an all-time low throughout the United States and then even throughout the world in terms of blood banking, and so we need to think about how to use less red cells, decrease the impact to quality of life, and certainly lower the risk of transformation to AML, and use things as long as they work. Expectation management throughout all of this is absolutely critical. So there's a number of agents that you'll hear about really from my colleagues for the treatment of patients with lower risk MDS. ESAs have been around forever, apparently when Guillermo was in Philadelphia, as he told us earlier. But I think they're still used in many parts of the world, though a little bit less as I see time go on even in my own career. Certainly where I come from in Baltimore, there's a significant problem with renal disease because of the patient population around the hospital, and so we still use them not uncommonly. Lenalidomide is most often used for deletion 5q disease. So thrombopoietin receptor agonists could probably be a whole discussion and diatribe about where they have a role, but they are used in some places for low-risk disease, predominantly with thrombocytopenia, so not the anemia we're focused on today. ATG-based regimens, when someone believes that the person they're treating has a real immune basis of their cytopenia, a little bit more akin to an aplastic anemia, something like that. Azacitidine and decitabine. Both oral and IV have been around for a while now and are really good drugs even in low-risk disease, even though mostly approved for high-risk disease throughout the world. Luspatercept we'll hear a lot about, and certainly imetelstat as well as our two newest friends in our therapeutic arsenal, especially for those with anemia predominant lower-risk MDS. They all have different mechanisms of action, and I think it's really critical, the talks that we heard before the break, to think about the biology of disease, what we're trying to do for these patients, and why we might choose each of these therapies differently. What's particularly important and a fun part, I think, in lower risk disease that is less true right now in higher risk disease is we have the ability to think about how we sequence these and how we go to and from a therapy and when to switch, when not to switch. And those are the genesis of some of the polling questions, and I think you guys already have some thoughts framed in this regard. So let's move to another question. This is a different type of case of a 75-year-old with, again, fatigue and anemia. And in this case, MDS was diagnosed by a blast count of 1.5%, little higher ring sideroblasts, little higher erythropoietin level at 350, and only an ASXL1 mutation. In this case, we're thinking about the sequencing. He's already been treated with luspatercept. His hemoglobin increased and his fatigue improved, but his transfusion needs have not been impacted. So which of these options might you choose going forward? Azacitidine, lenalidomide, ivosidenib, or imetelstat? Okay, so I think no one picked lenalidomide because he doesn't have a 5q. He also doesn't have an IDH1 mutation. We have some very strong HMA advocates throughout each question, which I think is great. And then many are using one of the newer kids on the block, which is imetelstat. And I think this is a very fair point of discussion. Hopefully my colleagues will share some data that may help with this going forward. In terms of the NCCN guidelines, and not to be too American-centric, because I think these are specific to here and sometimes valued more or less, but it is helpful, at least in terms of how these are reimbursed for the patients and thinking about a framework for these patients. So those with symptomatic anemia lacking a 5q, very much like this gentleman, with or without other cytogenetic abnormalities and ring sideroblasts of less than 15% or less than 5% only with an SF3B1 mutation, is one panel in the NCCN guidelines for the management of lower risk disease. It's interesting because we still have listed in the preferred box EPO or an ESA or luspatercept, and these are all ORs. That's to make sure we don't relegate something to lack of coverage, and these are category 1s. Imetelstat falls in there as well, which I think was a source of a fair amount of debate, and I noticed some of you voted for it in the very first prompt, so something to think about. When someone has a high baseline EPO, we're far less likely to use it, and I think that stands to reason. And obviously, the targeted agents for IDH1 have a very specific profile only. But there's really some issues with our current management, and it's still affecting our patients adversely. We need to figure out how to impact their decreased quality of life and that time in the chair, because even if somebody is on luspatercept, they still have to come into the clinic, get their labs checked, decide to get a shot. The pharmacy has to make it. I mean, it's not like we're completely negating the problem. The healthcare costs continue to be an issue for all these patients, then complications due to iron overload. And I think later we may hear from one of our cardiology colleagues, because this can be quite impactful to other organs, both the heart and the liver. And you heard really eloquently about how it increases mortality the more transfusion dependent a patient is. ESA-related issues, I think, could honestly roll over into luspatercept. There's just more data, given the historical use of ESAs, about the dosing frequency, the lack of response. You saw Mateo's pie chart, which I thought was very helpful. And then certainly, at least in the US, the reimbursement issues are increasingly complicated. They're still really good drugs, though, and so in terms of the response rates, if you look across historical literature, they're 15 to 40%, and mostly used when the baseline erythropoietin level is less than 500, sometimes less than 200. We purposely chose cases today where it was a bit higher, so as maybe not to confound the response. But I do think these are still a viable option. You just have to think about what contribution there may be of chronic renal insufficiency or other details to their level of anemia. But these drugs are still out there, just used a little bit less these days. And this is a similar pie chart from a nice paper in terms of how these non-del(5q) patients do when they get an ESA. I think we'll be able to make these pie charts for luspatercept once we're a little further out from the COMMAND study. Lenalidomide was actually something nobody voted for without deletion 5q, and Dr. Santini led a very elegant randomized trial, which is our highest level of data, you'll recall, in lower risk patients who had previously been unresponsive or refractory to ESAs. And as I alluded to, I think as we think about the sequencing, this drug is not going to go away because it's always going to be there for 5q. Do we need to think about if it does or does not have a role in the non-del 5q patients? Because it did have about a 25% rate of transfusion independence for these patients. It has a little bit more myelosuppression, but I think we can compare and contrast perhaps later about the imetelstat experience when we think about drugs that have disease-modifying ability in lower risk MDS and where we think they have their time in the therapeutic window. It's something I like to think about, and I still discuss this with patients. I'll admit I use it relatively little in non-del 5q, but I think it is a viable therapy still. So is lower risk MDS really lower risk? And I think this becomes the question as you think about the talk all of us give. We've talked about how it increases mortality. We've talked about how the detriment to their quality of life is quite impactful. And the cause of death is often MDS related, as you see in the bar graph there. Certainly they can have other issues, but a lot of this is still related to what we're calling a low-risk disease, and that gets back to my point about expectation management. We really have to think about drugs and regimens and whole comprehensive plans for these patients so that perhaps we're able to decrease the MDS-related causes of death. And with that, I'll turn it over to my colleague, Dr. I don't know, are you next? I don't know.
Okay, I had an excellent introduction. And what about a patient with transfusion-dependent, very low-risk MDS without ring sideroblast and ESA naive? Would you recommend this patient for Luspatercept as first-line therapy? And these are the answers, so please vote and see what we may discuss on this point. So, very low risk, no ring sideroblast, transfusion dependent, ESA naive. Okay, I think we may discuss something, but, oh, okay. Okay, I think that we may treat this patient with Luspatercept, starting with a dose, and we will see in the next question. Oh, sorry. So if you think about a patient like this one, you may have a low-risk MDS patient treated with Luspatercept as first-line therapy for anemia, but which dosing strategy do you keep? And would you use 1 milligram per kilogram sub-Q every 3 weeks, or 1.75 to start with, or you just start with 1 milligram per kilogram square meter, sub-Q, and then you go up with the dose of the drug, titrating it until you reach response and durable response. Please. Okay, wow. So actually, this is not always done. Sometimes patients are kept on the lower dose for a long time, and we do not see the response that we could see. Actually, we can treat with lower dose, titrate it, and when the patient reaches the response, then we can try to de-escalate the dose of the drug and maintain the response with a lower level. So how did we learn to use Luspatercept? The first randomized study was Medalist. We all know these, and was dedicated only to the inclusion of patients who had MDS with ring sideroblast. Why is that? Because there was a phase 2 trial led by the German MDS group, and Uwe Pletzbecker was the principal investigator, in which Luspatercept was used in anemic patients with low-risk MDS all subtype, but the subtype that responded better, 77% of hematological improvement, was in fact the one with ring sideroblast. And at that stage, then later also was shown that if the patient had SF3B1 mutation, were even more responsive. So this was the design of the trial. The inclusion criteria, I told you, transfusion-dependent patients with a comparison to patient receiving supportive care. So the patient did not have received other treatment but ESAs, no lenalidomide, no hypomethylating agents, non-del(5q patient. This is a leitmotif of all the lower risk MDS, never including del(5q. And Luspa was compared to placebo. Of course, we had the possibility to titrate the drug, and the response was evaluated at 6 months for 24 weeks. So these are the first data that were published in 2020 in New England, and you see that here the response rate in terms of achievement of transfusion independence longer than 8 weeks was achieved when measured at 24 weeks was 38%. In fact, if you prolong the observation of this patient and you consider the entire treatment period, the percent of patients achieving these 8 weeks or more of transfusion independence rises up to 47.7%. So we can say that if you keep on treating patients, half of the patients will respond with transfusion independence. And the duration of the response is also quite important. Okay, duration of response is very prolonged, especially if the patient achieved 8 weeks transfusion independence. In the majority of cases, let's say almost 42% of them will be and maintain transfusion independence for 1 year or more. So this means that once you respond to luspatercept and keep on being treated, you can maintain this transfusion independence for a long time. And if you consider cumulative time of transfusion independence, meaning you may have a period in which you lose response and you need a sporadic transfusion, but you keep on being treated and have another period of long transfusion independence, this is also even achieved and maintained for a longer period by a higher number of patients. If this first transfusion independence is not 8 weeks, but is more than 16 weeks, then the percentage of the person responding, can achieve 1 year or more transfusion independence in a very high proportion of cases. Meaning, what is the meaning of all this? We keep on treating patients if they have a response. You don't have to stop, even if they need an extra help and 1 transfusion in the period of treatment, because they can re-achieve complete transfusion independence. What about side effects? So one of the side effects that was claimed in the very first period of this treatment was fatigue. Now, of course, fatigue is correlated with the degree of anemia, and it was sometimes reported as a side effect of the drug. In fact, it was quite clear that it was not related to the dose of the drug, with the patients receiving a highest dose showing the lowest degree of fatigue. Fatigue is also decreasing over cycles and continuing treatment. And what is more interesting is that fatigue is presented mainly by patients who had a lower hemoglobin level, indicating that it's probably only due to the hemoglobin level. Now, we do have some very, very rare patients who have this fatigue that is possibly correlated to the drug. We still have to understand who they are and what are the characteristics of these very rare patients, but still present. Now, I showed you the very first data that indicated a very strong activity of luspatercept in MDS with ring sideroblast. But there was another question. What if we start earlier to treat this patient with anemia? So this patient with transfusion-dependent anemia, low-risk MDS, can be treated with luspatercept in a very efficient way. And this is why the COMMANDS trial was designed. In this trial, luspatercept, same dose, titration, was used in all subtype of lower risk MDS, except MDS del 5Q. And it was compared with the treatment with ESA at standard dose. Now, these patients, again, were patients treated receiving regular transfusion. We know that ESAs are not so active in this type of population, so we really needed a new agent. Again, the principal endpoint was to evaluate transfusion independence, this time longer than 12 weeks, and with an addition of 1.5 gram deciliter more of hemoglobin on top of the transfusion independence. So very stringent criteria. And again, measured at 6 months. Now, it was very clear that luspatercept could in fact induce this longer transfusion independence and increase of hemoglobin with respect to ESAs. You see here the percentage of 60% of patients responding and keeping the response for more than 8 weeks. And this irrespective of many variables that we know are important in anemic MDS patients, like baseline EPO level or the number of transfusions. And of course, what was very interesting was to see whether it would work in RS negative patients. And where in the beginning, so with a shorter follow-up and measuring response at 6 months was showing, let's say, almost equal results with patients without ring sideroblast between luspatercept and ESA. If you analyze the patient who had transfusion independence longer than 6 months, you see that in fact even ring sideroblast negative patients do respond better, longer to luspatercept than to ESAs. And the overall response with longer transfusion independence than 6 months is clearly shown much more frequently by patients who receive luspatercept. And as Dr. Garcia-Manero just mentioned, in fact, this is not only increasing the hemoglobin, is not only abolishing transfusion for a substantial and significant number of months, in this case, but is also bringing some important results in terms of survival. So not only we improve the quality of life of this patient, but we may prolong their survival in a significant manner. And this is the data that are quite impressive of patients who respond to luspatercept and who have a longer follow-up than longer than 2.5 years. And this is actually a landmark analysis at 3 years. You see that the patients do have a significant prolongation in survival when they're responsive for such a long time. So it's a very important finding and very important observation. We had some hints that when we had only ESAs to use, also we could show that there was an increase and an improvement in survival if the patients were responsive for a long time. But this is really an impressive result now. Now, we changed gear completely, and from the TGF-beta inhibition and TGF-beta family inhibition, we go to the telomerase inhibition. Now, there is another agent that is imetelstat, that is a competitor of telomerase, inhibitor of telomerase. And because of the background, let's say the activity of telomerase in dysplastic and leukemic cells, it was thought that blocking it could be of advantage of patients with MDS, and a previous study was involving patients with myelofibrosis. So the patient population included in this phase 3 trial comparing imetelstat to placebo was very similar to the previous eligibility criteria shown for the Luspatercept trials. These patients were patients who had received ESAs or were ineligible for ESAs with higher EPO levels, or they had responded and then relapsed after ESAs. These patients were not only MDS-RS, but all MDS subtype, again, with the exception of the MDS del5Q. The other characteristics of this study was that the patient had to be transfusion dependent, but their transfusion dependence had to be, as you see, higher than 4 units of red blood cells in 8 weeks. So high transfusion burden, as it was established as a landmark and as a threshold. Again, transfusion independence longer than 8 weeks, measured at 6 months, with a lot of other. So this study also was successful in showing a transfusion independence in 40% of patients who receive imetelstat versus 15% who received the placebo. And 70% of these patients achieving transfusion independence longer than 8 weeks moved to have a 6-month transfusion independence. And of these, more than 70% in fact, achieved more than 1 year stable transfusion independence. So once again, the patients who respond and keep on being treated can be the one who maintain this transfusion independence, and thus a serious and significant improvement in quality of life for a very long time. What is also quite interesting is that the therapy with imetelstat can maintain levels of hemoglobin that are not just above the threshold of transfusions, so 8.5 or 9 grams deciliter, but they may really be much higher. And we know that, we just heard, that the higher level of hemoglobin you can reach, the best performance and the best improvement in your general condition, and finally in quality of life is. So these patients, especially the ones who have more than 1 year transfusion independence, have near normal or normal levels of hemoglobin, 13 grams deciliter. So this is also something very interesting. These patients do deserve to have high levels of hemoglobin that allow them to have and live a normal life. So I think I give you the stage.
Thank you, Amy and Valeria, for setting the stage. Good evening, everyone. I think I'm one of the few people that do both MDS and MPN, so this is very exciting to see the crosstalk because I think there is a lot of similarities, but to John's point, there is also actually differences. We borrow a lot of the drugs. The line between those diseases is really sometimes very fine, but we see differences in responses to treatment. Actually, the criteria to define transfusion dependent or independent are completely different, and you have to really memorize them on each side to know how to even speak the lingo between those two. I'm going to talk about probably what's on the short horizon for the patients with MDS, but I think on the long term, we have to go back and to think to something fundamental Dr. De La Porta mentioned today, that the ineffective erythropoiesis in MDS have totally underlying different mechanisms based on the subtype. And we really have to think of that. So we have deletion 5q, SF3B1, maybe now we start thinking of IDH inhibitors in lower risk MDS, because that's also 5% of the patients. It's equivalent to deletion 5q, but yet we don't think of it. The next time you see a patient in clinic with deletion 20q and UTAF, look at their bilirubin. It's going to be 4, I guarantee you, because they have ineffective hematopoiesis from hemolysis and low haptoglobins, and those patients may have different mechanisms. So that will be key as we think in the future. Now, in the short term, I'll focus on some of the ongoing trials. I wanted to start with this as kind of my personal thing, how I sequence the treatments in lower risk MDS, kind of wrapping what Amy and Dr. Santini were mentioning in their presentation. We will never have data to address the sequence of therapies or study that will go sequential with all of those things. And I think we have just to extrapolate from some of the studies we have. And, and the principle is really the totality of the therapy, based on the chance of response with each line and the duration that we are going to respond. So for del5q, I think lenalidomide in most of the cases, Guillermo mentioned earlier also, maybe even moving it earlier on. For patients with MDS SF3B1, I think if their serum EPO is above 500, those patients with serum above 500 really don't respond much to any ESAs or AMAs, but they are only 10% of the patients at time of diagnosis, so it's not a large subset of the patients. So 90% of the patients will have an EPO level below 500. I think from the COMMANDS data and all collective data, there is clearly that Luspa should be first line in patients with ring sideroblast or SF3B1. At time of failure, there is probably an opportunity for adding ESA to Luspatercept, and I'll show you some data. And then we go emtelestat, and we keep going down the road. In patients with no ring sideroblast, if their EPO level is above 500, as Dr. Dezern showed in her presentation, think younger patients, immunosuppressive therapy, and emtelestat. If patients have low serum EPO, I don't think we have conclusive evidence yet which would be the first line of therapy, ESA or Luspa. Based on what we see currently, I think if you start with Luspa, with ESA, add Luspa later on, then go to emtelestat, that probably will be the best sequence. But that's my own read of all the data, percentages of response, and the duration of response. So, moving forward, I think one thing very important, and again, Dr. Garcia-Manero touched on this, is basically moving the treatment earlier, optimizing doses of some therapies, combination therapies, novel and targeted agents. So I think one of the most important ongoing studies is really this ELEMENT study, because it's testing this principle of earlier treatment. Historically, so far, every drug we got approved in MDS is based on transfusion independency. Patients have to have anemia that's transfusion dependent. There is a lot of people that are skeptical about the earlier treatment and the benefit for patients with symptomatic anemia. And this study will be key to answer that. So patients with lower risk that are not transfusion dependent are randomized between Luspa, ESA, similar to the COMMANDS data, but the primary endpoint is really looking at the rate or the conversion of transfusion dependency up to 96 weeks on the study. So I think this will be a very important study, not just for the Luspatercept, but for the field in general, to prove the benefit of treatment of symptomatic anemia. So this study is open and enrolling. Now, also, Dr. Santini mentioned a little bit about the dosing of Luspatercept. When we originally were developing those drugs, there was really a lot of restrictions applied by the regulation authorities for the safety, because those were new classes of drugs. We were not allowed even to escalate the doses of those drugs. And clearly, the response is dose dependent. If you look at the data from the Medalist study, a patient that is that's heavily transfusion dependent, almost zero would respond to the 1 or 1.33 level. So you really almost have to go to 1.75. So the Maxillus study has been trying to look at that. Dr. De La Porta presented some data at EHA. There are 2 cohorts, one ESA naive and one patients that are post-ESA failure. And the bottom line, we are seeing early encouraging results, high responses. It's a mixed population, still small numbers. But the most important also that there is no really a signal of increased toxicity with a higher dose. So definitely, we should be considering the higher dosing, at least escalating in patients, especially if they are like higher transfusion burden. So we'll see more with this study as well. Now, I talked a little bit about the combination therapies. So this is a case series actually we published a couple of years ago now. So this is predominantly RS positive patients, because at that time Luspa was mostly used for RS positive patients. And so we took patients that had ESA failure up front, Luspa failure, and then we did the combination of ESA Luspa. And what we observed is almost around 30% capturing response again with the combination. It tends to be more in patients that have EPO level above 500, below 500, sorry, and if they had some response to luspatercept, a secondary luspa failure. So if a patient with RS positive started with luspatercept and had some response, and you're starting seeing the failure, maybe there is opportunity to add the ESA and gain some response again. Again, this was like a case series, but this is probably the best we have, at least in the RS positive. This is not advancing. So now the French had been looking at the same way in a more elegant title called the Combola study. And they are really taking in this study the RS negative patients. So our cohort was mostly RS positive. So in their study, they took RS negative patients that had ESA failure and added luspatercept. And in reality, when you look at the baseline characteristics for those patients, they were really a little bit higher risk population of the what we define in the lower risk. And yet we still see around 30% responses to the combination of ESA, Luspa. This was the first read on the study. They decided that going forward, the 1.75 dosing is to go. But it still gives you some evidence that if patients were treated with ESA and the lower risk MDS, and you come back with a combination in the non-del5, non-RS, that you'll probably see around 30% responses. Another drug interesting that had entered now the phase 3 trial is elritercept. So elritercept is similar a little bit to sotatercept. It's an activin A fusion trap protein rather than activin B with luspatercept. Obviously it neutralizes TGF-beta ligands. Some differences, maybe some trilineage responses with elritercept, bone remodeling effect. But the phase 1, phase 2 had been ongoing predominantly in Europe, and had been showing encouraging data in patients with MDS, lower risk, both RS positive, RS negative, and as well as high transfusion burden. But similar to the phenomena with ESA and luspatercept, we see better responses when the endogenous serum EPO level is less than 500. So based on this, there is ongoing study that's now open and active called the RENEW trial, which is similar to the medalist design in reality, but both RS positive, RS negative. So this is ESA failure, transfusion dependent, lower risk MDS patients, randomized between elritercept and placebo with a primary endpoint of 8 weeks transfusion independence. And hopefully the study will be the entry study for later on moving this agent as well further. And I know from MPN, and probably there'll be discussed a little bit, that this drug also has some promising activity in MPN and will be tested also in MPN. Now, another obviously way to think of treating MDS, knowing the role of inflammation. And I think when you look at some of the data of survival, like we are starting to see with luspatercept in the COMMAND study, you start wondering, is it all just the anemia response, or we are modulating inflammation, decreasing cardiac mortality, all that stuff? Because inflammation is key. And I think one of the main reasons of mortality in the lower risk MDS, I used to think of it very simply: anemia worsens coronary artery disease, somebody gets more unstable angina. But it's probably also the mutations, the CHIP, the CCUS, and the inflammation that's contributing to the cardiovascular mortality. And I think in some of the upcoming trials, we should really looking at those major cardiac events as an endpoint in our trials. So I think Guillermo and I can count probably 6, 7 trials we've done together with anti-inflammatory drugs, from AKT, MAP kinase inhibitors, RA614, to toll-like receptors. I think our problem in the past, partly mandated by the FDA, is that all those studies required HMA failure in the lower risk MDS. And that, I think, is a late opportunity to intervene with anti-inflammatory agents. Those should be moved earlier, maybe in the CCUS, maybe after ESA failure. But if you are going to come at HMA failure, it's probably too late in the game. There are still few promising ongoing. There is the NLRP inhibitors. There is a compound in clinical trials. There is IRAK1, IRAK4. There is anti-interleukin drugs. Again, I will not have the time to go through those in details. I think the key really to think of those agents, to move them earlier on, maybe even in the pre-MDS situation, to see the benefit of those drugs. And it seems there are some subsets that will benefit. Like I think from the canakinumab data that Guillermo presented as well, we see that certain subsets like TET2, DNMT3A benefited more from that agent. And finally, obviously, we have opportunity to have some targeted therapies, even in the lower risk. Again, as I mentioned, if you look at IDH1, IDH2 collectively, those are around 10% of MDS altogether. They tend to be more higher risk, but there is a subset clearly of lower risk MDS that will harbor either IDH1, IDH2 mutation. Those first are at higher risk of developing AML than other subsets, and they can go directly to AML, not a stepwise. They are clinically characterized by severe neutropenia, typically, that you really have no other agents other than immunosuppressive therapy for younger patients that work well for neutropenia. Azacitidine response for a neutrophil response is 19%. So those patients will have a good response. And also we are observing a lot of autoimmune-related diseases described in patients with IDH mutation, that some of patients are symptomatic from even connective tissue disease point that there could be opportunity to treat. There is ongoing trials, obviously, with IDH inhibitors in both lower and higher risk MDS. I listed here a couple of the trials from the French group, both in IDH1, IDH2. There is a cohort that's a small number of patients in the lower risk, but more than 50% responses, anemia response. We've reported anecdotally a subset of patients that had severe neutropenia, that had recurrent infections. We treated with IDH inhibitors that have a very long response for the treatment.